Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Today we are starting part 1 of CPT Evaluation and Management. The Evaluation and Management section, E&M, is the first section in your CPT book. The reason for this is because most coders use this section more than any other section due to the fact that patients must first be evaluated, and the decision on how to manage the patient must be determined before any anesthesia or surgery can occur. All codes in the E&M section begin with the number 9. So let's distinguish between a new and an established patient. A new patient is one who has not received any professional services within the past 3 years from a given physician or another physician of the same specialty who belongs to the same group practice. An established patient is one who has received professional services within the past 3 years from that physician or another one of the same specialty who belongs to the same group. Please understand that professional services in other sections of CPT can be things like x-rays, pathology services, electrocardiogram, stuff like that. Some of which may or may not be face-to-face. But the definition of professional services in the Evaluation and Management section is trying to say that in order to qualify for a particular level of E&M service, the patient and the physician or other healthcare professional must be face-to-face with the patient. Okay? So there's a decision tree in your guidelines at the beginning of your CPT book. And what I love about decision trees is they give you direction. The first box says, it asks you, has the patient received any professional services from the physician or another physician in that group, that same specialty group, within the past 3 years? If you say no, then it tells you to use a new patient code. But if it's yes, then the next question says, is that physician of this exact same specialty? If you say no, then it's a new patient. But if you say yes, then it's an established patient. So that right there, that decision tree that's found at the front in your guidelines of your E&M guidelines, at the front of your E&M section in your CPT book, that decision tree will help you. But it's letting you know the 3 key components: has or has not been seen in the last 3 years, physician has the same specialty, has the same specialties, and belong to the same group. So you can be a patient that was seen in the past 3 years, but that specialty of your physician might be different than another physician in that same group. But if that specialty is different, you could be a new patient to that physician in that same group. So those are the key indicators right there. Within time, 3 years, specialty, and group. Okay? All right. So let's talk about visit codes. Once you determine whether your patient is new or established, you must then decide which E&M code or visit to use. One of the best things you can do for your office is to keep in mind that evaluation and management codes deal with what your physician does during the time spent with the patient, rather than merely with the amount of time spent. Let me say that again. Codes in the E&M section deal with what your physician does during the time spent with the patient, rather than merely just on the amount of time spent with the patient. By not paying attention to what is or is not included in each of your visit codes, a coder can cost his or her physician a considerable amount of both time and money. As you examine the E&M section, you will see that many of the services described have something in common. For example, they mention some sort of history, some sort of exam, and some sort of medical decision making. These are called key components. To code levels of service accurately, you must be sure that 2 or 3 key components, depending on the category of service, for example, whether it's a new or an established patient, or whether this is the initial or a subsequent visit. Okay? A key component is to an E&M visit an important necessary ingredient. A key component is to an E&M visit what an important necessary ingredient is to a recipe. For example, without the cheese, it isn't cheesecake, right? Well, likewise, without your key components, it's not an E&M visit. Watch how I introduce this to you in a format of making a cheesecake. Most E&M codes contain the following general components. Ingredients: history, exam, medical decision-making, counseling, coordination of care, nature of your presenting problem, and time. However, not all of these are considered key components for the visit. Just the vanilla extract, the milk, and the sour cream are not considered key ingredients for cheesecake. Make sense? Key components for E&M codes listed in CPT are the following: your history, your cheese, your examination, your graham cracker crust, and your medical decision making, your eggs. When you look at E&M code, for example, 99201, code 99201, you can see the key ingredients that we are talking about. That is, you can see the description of the code lists a kind of history, a kind of exam, and a kind of medical decision making. Without these components, the service would not be considered an E&M code. When you refer back to that 99201 code, you will see that some of the terms describing the different key components, for example, problem focused, expanded problem focused, something like that, they're used for both the history and the examination. Since we are comparing E&M services to a recipe, think of these terms in that same sense. In other words, think of these terms like problem focused, expanded problem focused, etc., as different measurements on a measuring cup. Don't be concerned about the fact that the same words are present, problem focused, expanded problem focused, okay? Don't be worried about that in both the history and examination, since the idea behind the term is the same. For example, you would not be concerned that your cheesecake recipe has a 1/4 cup of a certain ingredient and a 1/2 cup of another. The fact is that the amount of each of the ingredients is different, just as the degree or the level of difficulty of the history and the examination is different. Okay? What matters is the different level of E&M is the level of action that is taking place. Whether the physician is taking a history or performing an examination, and how in-depth or how much of a cupful of service he's giving. A lot of people have great difficulty deciding which E&M code to pick for the service that they provide. Take your time and make sure that you understand each concept before moving on to the next. I'll be putting this information together for you in an unusual format, which will help you consolidate your thoughts and the different components into a code selection that will appropriately describe the kind of E&M service you provide to your patient. For right now, let's discuss each kind of history and exam, remembering that the different kinds of histories and exams are just like the different measurements on your measuring cup. The higher the level is for the history and exam, the higher the measurement is on your cup. Always look at the history and exam independently of each other. This would be the same as when you make a cake. You would measure the eggs independently of the oil. It is the combination of them, all the ingredients together, that makes the cake, right? Likewise, it's the combination of the key components, history, exam, and medical decision making, that make up the E&M service. So, let's break down histories today. Many of the E&M services include main ingredients, right? These are the histories, the exams, and the medical decision-making process. For example, what are we going to do to make this patient better? So in looking at the history portion of the E&M codes, note that there are several different types of histories that a physician can provide. These include a past history, a social history, a review of systems, and a family history. So let's look at them each individually. Past history. Past history is where the doctor gets information on prior medical illnesses or injuries, operations and or hospitalizations, current meds, allergies, immunization status, and age-appropriate feeding on dietary status. Social history is where the doctor gets information on the marital status or living arrangements of the patient's current employment, and their occupational history, the patient's level of education, their degree of tobacco, drug, and alcohol use, their sexual history, and any other pertinent social factors. A review of the patient's symptoms, fever, weight loss, and other system reviews such as eyes, musculoskeletal, ears, etc. can also be obtained during this history if the patient is experiencing any problems with or has any problems with these symptoms. And then a family history is one in which the physician obtains information about the patient's family as it may have significance for the patient. For example, past cancer in family members, etc. A family history may include information about the patient's parents, siblings, children, specific diseases that any of these family members may have had, either as these diseases relate to the reason that the patient is currently being seen, or as these diseases or conditions may be hereditary or place the patient at risk in the future. So as you can see, by understanding the kinds of histories that can be obtained, it will be easier to understand that the level of the histories that need to be taken into an account. For example, the higher the level of history obtained, the more information that the physician needs to obtain from the patient. Let's take an example. Let's say that a physician has obtained a complete social history and complete past and family histories. When histories like this, which include getting information on the patient's past, social, and family history, are obtained and are in depth, this kind of history qualifies as a comprehensive history. It is when you don't get all of the different kinds of histories, when you don't get a complete social history or a complete family history or a complete past history, that the level of history that you choose for the E&M service changes. Okay, for example, let's say that a patient comes in to see you and they only need to get their prescription refilled. It would be inappropriate for you to go into their complete social, past, and complete family history, as you already have all that information, and all you really need to do is update their condition and get some information about the reason that they are here to see you today. Obviously, this visit would not qualify as a comprehensive type of history. In order to fully understand the dynamics behind the correct coding of E&M codes, when deciding the kind of history that was provided by the physician, one must understand the different levels of histories outlined by the AMA, American Medical Association. So there are 4 levels to describe in CPT. And y'all, they're in your guidelines in the front of the E&M section in your CPT book. There are 4 levels: problem-focused history, expanded problem focus history, detailed history, and comprehensive history. So let's look at each one of them separately. Let's start with a problem focus history. And if I were to measure that with making my cheesecake, I'd say it's just a pinch. Problem focus history, just a pinch. A problem focus history is one in which the physician, one, obtains the chief complaint. Why are you here today? And takes a brief history of the present illness or problems. When did the problem first occur? Was there anything that precipitated the problem? So you see those two questions your physician would ask. A problem focus history is the kind that your physician would take from a patient who comes in with a rash that looks like poison ivy. This kind of history might be taken if an out-of-town patient needs a prescription refilled. The physician focuses on the problem at hand. That is, he or she is not necessarily concerned with the fact that the patient may have, in addition to a rash, a broken leg or diabetes. Questions your physician may ask of a problem-focused history include, but are not limited to, what is the problem? How long have you had this problem? Are you taking any medications? Are you allergic to anything as far as you know? Problem-focused histories are the simplest form of histories that can be taken. Just a pinch of an ingredient is about the simplest version of an ingredient that you could possibly have. Just a pinch. The next level is an expanded problem-focused history. Let's look at that as a third cup, 1/3 cup measurement. An expanded problem-focused history goes a little further than the problem-focused one. As its name implies, this type of history is expanded or enlarged so that the physician obtains more information than he did in the problem-focused history. In an expanded problem-focused history, the physician, number one, obtains the chief complaint, takes a brief history of the present illness or problem, and conducts a problem-pertinent system review. Let's describe what a problem-pertinent system review is and how that makes an expanded problem-focused history different from a problem-focused history. Systems that may receive the problem-pertinent system review include your eyes, your ears, nose, mouth, and throat, which is considered ENT, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, integumentary, neurological, psychiatric, endocrine, hematologic, lymphatic, immunologic, and allergic. And then your constitutional symptoms such as fever and weight loss. Your physician would take this kind of history from a male patient who comes in with severe cystic acne. For example, your skin and your integumentary system, because the acne affects the integumentary system and may impact more than just one body part. For example, it may expand to include your head, your neck, and your shoulders. Okay? Another example would be from a female child with a sore throat and a headache. ENT and possibly neurologic symptoms, which obviously affect more than one body part, but are still relatively simple to diagnose and treat. A question your physician may ask as part of an expanded problem-focused history include, but are not limited to, what's the problem? How long have you had this problem? Are you taking any medications? Are you allergic to anything that you know of? Do you know what may be contributing to your problem? Are you experiencing this problem anywhere else? Notice that this kind of history is slightly more involved than the problem-focused one. Okay? See how we got a little bit more? Now let's go to the detail. Now we move to 2/3. We've gone from a pinch to a third to 2/3 cup. Detailed history. In a detailed history, the physician does the following. 1. Obtains the chief complaint. 2. Takes an extended history of the present illness or problem. 3. Completes a problem pertinent system review that includes a review of a limited number of additional systems. And 4. Acquires a pertinent past, family, and or social history directly related to the patient's problem. The major difference between the two previous histories, which was problem-focused and expanded problem-focused, and now with detailed history, is that a detailed history is one in which the physician obtains information about the patient's past history, the patient's family history, and or the patient's social history. None of these kinds of histories were required as part of the problem-focused or the expanded problem-focused histories. An example of a detailed history may be from a patient with a recurrent low back pain, for example, musculoskeletal system, that radiates to the leg, neurological system, or a patient with progressive scoliosis. Notice that the condition, for example, recurrent back pain or progressive scoliosis, are more complicated than the examples we've discussed earlier. In a detailed history, you will see that more information and background of the patient and the problem is required in order to make a definitive diagnosis. In the first case, that of the low back pain, in addition to get the information that you would in the lower levels of history, the physician must explore events in the patient's past that may have contributed to his current complaint. For example, she might ask the patient what he does for a living and whether he has been doing anything at work or athletically that might have caused him to strain his back. And in the second case, that of the progressive scoliosis, the physician explores the patient's family history, perhaps asking her if anyone in her family has ever been diagnosed with curvature of the spine or if any other treatments have been given for the condition. Okay, so see how we've expanded, gotten into some more social family history. And now the comprehensive history. Now we're at a full cup. We've gone from a pinch to a third to 2/3. The comprehensive history is a full cup. During a comprehensive history, the physician performs the following. 1. Obtains the chief complaint. 2. Takes an extended history on the present illness or problem. 3. Reviews the systems directly related to the problem or problems, as well as all additional body systems that have been identified in the chief complaint as being important. And 4. Acquires a complete past, family, and social history. Notice that the major difference between a comprehensive history and a detailed one is that the comprehensive history, in a comprehensive history, the patient receives a complete past patient history and a complete past social history and a complete past family history. These 3 types of histories must be included in order for a service to qualify as a comprehensive history. As an example of the comprehensive history, consider the initial visit of a 73-year-old man with an unexplained 20-pound weight loss. We would ask about the gastrointestinal system, the hematologic, lymphatic, and immunological systems, as well as pose questions about the heart, cardiovascular, and lung, respiratory, and review details concerning the eyes, ears, nose, and throat, right? We would also want to know about any family information, any history of cancer or diabetes in your family, as well as the health status of any siblings and or children, and any other diseases related to the reason that the patient is here. In addition to this, we would obtain information on the patient's use of drugs, alcohol, and tobacco, his level of education, his sexual history, and his preferences, his current employment, his hobbies or retirement status, his marital status, and any other relevant factors. Okay, so you see how we're going from a pinch to a third to 2/3 to a cup. Okay, different levels of history. So in conclusion, regardless of the amount of detailed information you choose to obtain, in your discussion with your patient, you can see that a history is a major ingredient in determining the appropriate diagnoses of a given patient on a particular visit. It is for this reason that the history is considered a key component of the visit. The more intricate the cause of the patient's complaint, for example, the more difficult it is to figure out the diagnoses, and the more information required from the patient in order to do so, the higher the level of history that you'll select. With patient information sheets that many physicians and offices and clinics currently employ, where the patient is asked about their past history, their social history, and their family history, and with proper review of these sheets as part of your E&M service, it's relatively easy to qualify for a comprehensive history on a new patient visit. Be careful, however, that you don't use the level of history as the only qualifier to select a particular level of service. Stay tuned as I review examination in the next video. Also, be sure to go to my other channel, Medical Coder Life, all one word, as I'm doing a series on physician documentation forms. I discuss each of the forms in the medical record that the physician is responsible for completing and from which I find my diagnoses and procedure codes. Okay guys, that's history. We still got examination and medical decision making when it comes to selecting our E&M code. So stay tuned. Thanks, and I'll see you in the next video.